But now I'd like to introduce our speakers for the evening, David and Lori Wylly. They are from Medicare Solutions Network, which is located locally here in Lisle. Their team helps people navigate the complicated world of Medicare. They are independent insurance brokers, and that means that they represent virtually all of the companies and products that make Medicare Part A and Part B. The foundation of their agency is education. And for 17 years and in 19 states, they have been helping people make fully informed decisions in the world of Medicare and even saving them thousands of dollars in the process. We've utilized David and his team previously as a resource here at the library with our patrons, and we welcome them here tonight to help shed a little light on what can be a very confusing topic. So without further ado, I would like to introduce David and Lori to present to us.
Good evening, everybody. Welcome to the wonderful world of Medicare. If you guys didn't know this, you might feel a lot like this guy right here, if my changer will work, and it doesn't. Interesting. Already have technical difficulty. Let's see if we spin the batteries, if that will work. Lower.
Yes.
Held. Nope.
The battery just died?
Yeah, it could be batteries just died. Well, okay. I'll give this to my technical assistant, see if she can work with it.
Working on your clicker.
I gotcha. What we want to do here tonight is talk about Medicare. Introductions are in order. Let's start with the basics. First of all, Lori and I are insurance agents. Please don't let that throw you. We're not here tonight selling anything. Tonight is all about education, understanding how the world of Medicare works. We're brokers. Why that's important? Because as a broker, we represent virtually all the companies in the marketplace. What you want to understand, this world of Medicare, robust competition that you can harness and use to your advantage if you understand how this landscape works. Many companies want your business and they're all beating each other over the head. But the beauty of this is you now have a new sheriff in town. You've got Medicare that's running this show. They're looking out for you. They're keeping the insurance companies on a short leash. They look out for the agents, making sure we're all above board, or at least they try. What we've been doing for 17 years, and Susan touched on it, the cornerstone of our business is education. If you don't understand how Medicare works, you can't appreciate it. And if you don't understand how it works, you might wind up spending way too much money down the road.
On your clicker.
I figured as much. Click away, baby.
Oh, wait, I think the presentation is frozen.
Ah,
That could be a
so,
problem.
okay. Maybe it's not our fault.
There
There
we
you
go.
go.
I'm gonna do it manually because the
Okay, good,
buttons
good,
don't
good.
work.
When you first come to Medicare, you'll feel a lot like this guy. It's very confusing. Your friends and family are over in that corner. Your mother-in-law's over here. The guy at work insists that you should be over here. And your friends and family mean you well. But I would tell you from experience, they probably don't fully comprehend what they've done. You approach 65, you'll be overwhelmed by the amount of mail that you get. You'll be overwhelmed by the phone calls that you get because you're a very attractive market to insurance agents because you're in your guaranteed enrollment. That means there's no underwriting, there's no medical questions. Katie, bar the door, come on down. As a result, you'll find yourself, if you know the numbers, it's staggering really. In 1958, these people that are turning 65 this year, we average over 12,000 a day. It's crazy big business, and that's why all the mail shows up. And this poor guy's got to try to figure out how to navigate this world, but you don't have to do it on your own. What we do is assist people. Yes, we work on commissions. That's how the insurance companies pay us. There's no charge to you for our services. But what we do is we shorten that learning curve. One of the places you would want to shorten your learning curve, hit it, Laura. There you go. Medicare U. This is the Bible of my industry. It does two things incredibly well. It's chock full of knowledge and it's a tremendous sleeping aid. If you have trouble dozing off, this thing will knock you down in short order. It's a government publication. That means they got to toe the middle ground. You won't get definitive answers out of this book. You get a lot of sort of kind of maybe, sometimes yes, sometimes no. But the ground rules of engagement here are really good. Understanding how drug programs work, understanding what supplements are, understanding what an advantage program is, and all the timetables that are involved in that. The book is backed up by a wonderful 800 phone number. You should write it down. It's 1-800-Medicare. They're there 24 hours a day to answer your questions. You can always tell good customer service. They give you their first name and their last name. And if they tell you they're gonna call, they will, but they won't call you unsolicited. As you approach 65, you'll get an awful lot of phone calls from people intimating that they might be with Medicare. They'll happily intimate that they've been assigned to your account and they're there to help you sign up. Beware, these are sales sharks. These are people that are calling you unsolicited. Difficult to say, but please don't take those calls. They'll spin you up, they'll scare you, and possibly sign you into something that you might not need. The book, the 800 number, backed up by a fabulous website. This is Medicare.gov, G-O-V. I don't know how they let Medicare.com come to market. It's confusing. People think that they're possibly looking at a Medicare site. They're not. They're looking at a sales site. That Medicare.com site confuses, but this is a wonderful source of information. Does my clicker work? Does my pointer work?
It might work.
Don't look like it. There you go.
There you go.
Let me, give me
So
my
you do
clicker. I
have
need to be
that.
in charge here. Okay. This idea of this website, and this right here is a wonderful source of info. All these are great sources of information, but this is what we're going to utilize a lot this time of year, finding health and drug programs. If you were not aware, we're headed now into the annual election period. This is where you get to make changes in your coverage if it's appropriate, if it makes sense. And that period goes from October 15th to December 7th. This is a critically important time frame. If you're already in the world of Medicare, you should have now received your annual notice of change. If you have a drug program or you have an Advantage program, they've got to tell you what's going on for next year. Medicare insists that these companies lay out for you any changes that have been made in your coverage for the next year. Please don't miss that annual notice of change. It's important to make changes. If we do that before December 7th, we always have people who call us December 8th, December 9th. It's a hard finish for us. People always say, gosh, open enrollment, that must be like being an accountant during tax season. And I say sort of, kind of, but not really, because the accountant can file an extension. We cannot. Call us on December 8th. I'm happy to meet with you next October and figure out if maybe we should have made a change. This world of competition, these drug programs are a great example. This very year, we've got 24 different drug programs, but they all got to play by Medicare rules. Medicare sets the master formulary, the meds that you could select. No one program covers them all. You see these drug programs run the gamut. The least expensive this year is $8. The most expensive is $135. As you might imagine, this guy's in pretty good shape. This guy's a wreck, but he'd pay a higher premium to get a broader selection of drugs at a lower cost on those drugs. We can check your meds every year, and we should. We do this with our clients just to make sure you're in the best place for next year. Very important on the drug programs, because this thing called the coverage gap or the donut hole. We'll talk more about that as we go forward, but there's really no excuse for you to fall in the donut hole next year and be surprised by that. We can see that coming 8 lanes wide. We harness competition with complete transparency. That's the beauty of how this system works. Now, still not going for me. What is Medicare? Pretty simply, it's the health insurance program for folks over 65. Typically, our parents would have activated Medicare the first day of the month in which they turned 65. The baby boomers are changing that dynamic quite a bit. We'll talk about that in a second. But this idea of that as long as you've worked 40 quarters or your spouse has worked 40 quarters, you're entitled to this Medicare benefit, and it's phenomenal coverage. It's just not complete. And that's what this sentence is highlighting here. Medicare was never designed to cover 100%. We can't afford it the way that it is, much less pick up the entire tab. You were always expected to have co-payments and co-insurance and deductibles and things of that nature. There's gaps that original Medicare doesn't cover. Most people after 65 would be looking at this product, but there's also a world of people who can come to Medicare under 65. They've been declared disabled, or perhaps they've been struck down by some dread disease, end-stage renal disease, Lou Gehrig's disease. Perhaps you go blind. These are people, tragic circumstance, but boy, this Medicare thing can be a godsend for them. Great coverage at way less than what they would pay in the open market. Those are unique situations. We deal with those people frequently, and they have their own unique set of circumstances that we'll touch on a little bit later. But understand the takeaway, the idea that Medicare was never designed to cover 100%. This is where your journey is going to begin. And I would put forth to you that if you looked at your mom and dad's card, you'd probably see that they both started their Medicare the first day of the month in which they turned 65. That used to be the golden finish line. You'd find yourself retiring, activating your social security, taking the grandkids fishing because you got your Medicare and now you're covered. But what we see here is a tectonic shift with the baby boomers. They're working, they're in better shape at 65 than most of their parents were at 55. They like the job, they like the coverage. And this represents one of the first potholes that we see people fall into too often. They're berated by your friends and family. They mean you well, but they're going to tell you you're turning 65. You've got to turn on Medicare. If you don't turn on Medicare, there's going to be big problems. Well, this world is a world of partial sentences and half truths and floating asterisks. You wouldn't even know we're there if you didn't educate yourself. What we'll find on this A and B, A has no premium and typically can't hurt you, but the B does have a premium, and that would hurt you if you continue to work. Where you work, there's more than 20 people that work there. That's called creditable coverage. That coverage remains in primary position. You wouldn't need to activate your Medicare. You could wait till further down the road. You've got the qualifying creditable coverage. It's in primary position. To pay Part B premiums could be a mistake. We ran into a gentleman, it would have been, actually his wife was signing up for him a couple of weeks ago, and he was declared disabled in 2000. In 2000, he activated his Medicare because he was told by his friends and family he had to do that. The problem was he stayed on his wife's coverage, his wife's creditable coverage, more than 20 people working there. Now they find out, too bad, in 2023, that he's been paying Part B premiums for something he never needed to activate. We figure that's somewhere between $35,000 and $40,000 that he's dropped on a benefit he never needed because her coverage was primary. They didn't understand the rules of engagement. We want to be way ahead of this curve where you're turning 65 and possibly activating this Medicare. For most people, if you've got employer coverage, you could go ahead and take the A. The A typically can't hurt you because it's got no premium. And it could ride shotgun with your coverage through work. But the B is the one we want to be very careful of. Do we need to activate that? Are we going to continue to work? What are we going to do in this field of play? Understanding we'd like to be well ahead of our activation dates. Medicare won't even want to hear from you more than 90 days out. You apply today and your birth month is still 6 months out. They're going to tell you, come back when you're 90 days out. There's too many baby boomers turning 65. They're overwhelmed. This idea of reviewing what we want to do before we get into this window, and this window could be 3 months before you come off of your employer coverage or 3 months before you turn 65, but let's be ahead of it to know what that landscape looks like. What we find in this world, there's only one way you're going to get this card automatically, and that's if you're receiving Social Security benefit payments. If you're receiving payments, they'll go ahead and snatch the Part B and send you the card automatically. If you don't want it, you can send it back. But that's the only way they'll send it to you automatically. There are no Medicare offices. There are Social Security offices. Medicare is a benefit that comes up under the umbrella of Social Security. But those are two different benefits. You don't have to have both. You can have one without the other. Medicare is the medical benefit. Social Security benefits, that's where they give you back less than you ever gave them. Okay, we can have one without the other. We don't have to have both. If we continue to work, we might want to take that Part A because it's some additional benefits. There's no premium for A. It could add some help, and we'll talk about that in a second. But the B, we want to be very particular about it. The only reason that you wouldn't activate A or B is if you're in an HSA, a health savings account. If you have a specific type of insurance that's allowing you to make tax-deductible contributions into your bank account, you don't want A or B because you can't make those contributions if you've got Medicare of either letter, okay? A and B good, A and B not complete. We need to know how to make it complete, but we also want to understand this idea of the Medicare Part B. B has a premium. The base premium on Part B is $164.90 per person per month. Everything in the world of Medicare is done individually. Back up a slide. One of the tectonic shifts when you come to Medicare, you've got to kind of check what you learned in your first 65 years at the door, where you've always been a couple, married couple, married, and you've been on the employer plan. The employer plan's been really good. But when you come to Medicare, when you turn 65, you have the ability to split up. And that's not a bad thing because by treating you individually, we can customize a program for you that could be totally different from the program that you're getting for your husband. And that's one of the beauties of Medicare. It is a bit overwhelming initially, but when you think about your employer coverage, remember that. They came to you once a year and said, here it is, take it or leave it. Everything that went into that plan was determined in the boardroom. There were elbows flying and heated exchanges. How are we going to make this health insurance thing affordable for our employees? Well, there's a network and there's a deductible and there's co-insurance and there's co-payments and there's a drug program and there's a wellness program. They made all those decisions and they brought you a one size fits most. Pretty good. Certainly like it. It's a good benefit. It's a good value when compared to the under 65 market. But they made all those decisions. Now you get to make those decisions. Very important to analyze where you are when you come to this world. The spouse is turning 65. The other spouse has turned 65 and continues to work. We frequently see where the world of Medicare and the additional coverage can be less than what the spouse is paying on the coverage. You would always think you're a married couple and they're charging you $500 a month. That's pretty simple. It's $250 on her and $250 on you. Yeah, they love you. You're working there. Of that $500, you could be as little as $150 of it. If you looked at the numbers involved, you'd find that your spouse is actually paying $350 a month to be on your coverage. That could open the door to coming to the world of Medicare and possibly getting far better coverage for less money. Not always, but about 50% of the time, we're seeing couples that if we split them, it's a better outcome based on better coverage and lower premiums. Okay, go. Part B, it's $164.90 per person, but understand this Medicare thing is really expensive. It's a big deal and it's a lot of money for the government. So how are they gonna feed the beast? Well, we know from a very early age, just like your income tax, the more you make, the more they take, and it's true in the world of Medicare as well. This thing here, this chart is called IRMA, your income related monthly adjustment amount. What that means is the more you make, the more they take. IRMA, based on MAGI, your modified adjusted gross income. They want to collect more money and the government is happy to participate in your success. What they're doing is they're in a bit of a time machine because they're tied to their computers. In 2023, they can only see what you made in 2021. They're looking at your 2022 returns and they're looking at what you made in 2021. It is possible a married couple making more than $194,000 a year, step up, pay more, step up, pay more, step up even more still. Not only do they hit you on the Part B, they also hit you on the drug program as well. Nowhere near as usurious, but more money that you would be paying based upon your level of success. Go back to the 164.90. This idea is going to trip up a lot of baby boomers. There's a lot of baby boomers out there right now that don't realize this thing is out there lurking, waiting for them. And they're doing nifty things like moving money from their 401k into their Roth IRA, where it's going to be tax-free. That's a great idea. But remember, the money you take from this and put into that, remember how you had to pay taxes on it? Mm-hmm. That's an income event. That's possibly going to steer you up into higher brackets. You sold stocks at a profit, used to happen, right? You would have that capital gain that's going in this bucket. We've got a couple, not last year, year before, they took money out of their 401k to help their daughter buy a condo. That was a lovely thing for them to do. They took out $5,000 too much. They swerved into this upper bracket, and now this year, they're each paying an additional $65.90 and another $12.20 on the drug program as well. They didn't need to do that if they understood these rules of engagement. Be aware, be protected, be forewarned. I love my government. I just don't want to give them one more nickel when they're already taking, okay? Go. There's 4 parts to Medicare. We'll tear them apart here tonight, but understand the basis, the foundation, the bedrock is going to be having Medicare A and B in place. A and B going to form the foundation. We're going to see here in just a minute how good A and B is. It's very good, but it's not complete. Once we've got A and B in place, we would certainly look to add a drug program. That would just be smart to have that. Or we may be interested in looking at Medicare Advantage. These are the things that are going to be advertised incessantly now on TV because we're in the annual election period, and you could choose to add an Advantage program. The dead giveaway on those types of ads, anytime you hear the buzz phrase, dental, vision, hearing, get all the benefits you're entitled to, that's an Advantage program. Different idea, Not a bad thing, but boy, the way they advertise it is very disingenuous. Go. We know, looking at this is the world of Medicare from the Goodyear blimp. I like it because it's so simplistic. Let's break it down into bite-sized chunks. Let's try to make it understandable and not overwhelm you with minutia. But this is the view of the Medicare world from the Goodyear blimp. We're looking down, understanding that we need A and B in place, to be able to do these other things. We understand that A and B is good, but not complete. I'll tear that apart in a second. But big picture, I've got A and B. Now what do? You come to a fork in the road and you've got two potential pathways to travel. One pathway called original Medicare. That's where we're going to add a drug program, add a supplement, and these three pieces acting in concert are going to combine to provide you the coverage as we age. Or there's the opportunity for an advantage program. And if you have your Medicare map, I want you to scratch out that word Medicare because they will be removing that this year. It's been confusing people because this really isn't Medicare. This is a private health insurance alternative. It doesn't have the same grabby name, but it's where a private insurance company would step in and literally replaces original Medicare. One card, one company, a little bit more network restrictive, co-payments for services. These aren't bad things, more of a pay-as-you-go model. But understand here, there's pluses and minuses. And here, there's the good and the bad. What we want to do is on an even field, try to show you both of these here tonight. What drives our conversation here tonight are your questions. If you have questions, sing out, because your questions are the same as everybody else's. We got anything so far? Okay, very good.
I
Please.
just have a question on the last one. When you say it will be a private, this would be changing to a private health insurance.
Mhm.
So being private, will a person have the choice to change it the next open window when it comes?
Yes, with an asterisk, okay? You're never handcuffed to anything. But understand that there are rules of engagement. You want to know if you start here with original Medicare and you come over to Advantage, can you go back to original Medicare? We're going to talk about that because it's very important to understand. It's not totally fluid, but you're also never handcuffed to anything. You've got options for coverage. Medicare Part A. If there's one word for Part A, I want you to write down facilities or buildings. That's the world of Part A. No premium. I always get a kick out of agents when they say it's free. A isn't free. You pay a boatload in taxes. They just don't charge you more when you come to the party. Please.
Well, A can cost a lot if you don't have enough quarters.
This is true too. That's why you want to marry someone that does. The A can have a premium. It's very rare that that happens, but there are some people who don't pay into the system. If you haven't worked and paid for 40 quarters, they start that Part A at $400. It's a lot of money.
What's the highest?
I'm sorry?
You know the highest amount?
No, and it's set for the people who don't have the quarters. The one that is graded for income, that's the Medicare Part B as in boy. That's the one where the more you make, the more they take. But the set, if you haven't worked 40 quarters, A is a set amount. I think this year it's 400 going to 440 next year, I believe. But that's not graded for income.
I'm pretty sure it could be over 500. I think there's different amounts that charge it.
I don't think on the A there is. I think on the B there is because that's graded for income. But in this world, A is the one word, facilities, buildings, please.
Once you choose one, does it stay with the state? Once you enroll, is it universal all over the country?
I promise you we'll get to that.
Okay.
Okay? You're putting the cart ahead of the horse. I promise you.
I'm really on square zero.
Understood.
So I'm just.
Well,
And
and that's
that's-
kind of why we're starting here, because you've got to understand what you get from A and B before you can understand all that other stuff.
Okay.
So,
Okay, baby steps, I promise.
No,
So-
don't worry. Thank you.
Got it. So A and B is all of your facilities, okay? No premium, but for most people, but clearly there are
oops, sorry,
there are
this
co-payments.
is the problem with this.
There you go. There's co-payments for services there's co-payments for your facilities when it gets to the Medicare Part A. The hospital is the most important building you could use, but it's not free. It's got a co-payment. Skilled nursing is a wonderful benefit, but it's got a co-payment. The home health services will send a medical professional right to your front door. They'll help you get back on your feet. And hospice, whether that was in a freestanding hospice facility or the privacy of your own home, you'd find that these all have co-payments. A has no premium, but it's got exposure. If all you're running with is original Medicare, you're gonna have co-payments for these services. The hospital. One night in the hospital this year is $1,600. That's your co-payment if all you have is original Medicare. Under Part A, that $1,600 would be for one night, but it starts a 60-day benefit period. So you go in for 2 nights for your appendectomy, it all goes well, you go home. 3 weeks later, you decide to have a heart attack and go back into the hospital. If you're within your benefit window, you don't pay the $1,600 again. But on day 61, be forewarned, that all resets. You could conceivably, if you did it wrong, you could hit that hospital copayment several times in a year with original Medicare. Skilled nursing, wonderful benefit. Medicare will cover you for up to 100 nights of skilled nursing. But understand how that breaks down. The first 20 nights would be no charge to you. The next 80 nights could be 200 nights, $200 per night copayment for those additional nights. That's going to add up. After 100 nights, understand that Medicare does not pay for custodial care. Medicare does not pay for coming over and mowing the lawn or doing the dishes. That's long-term care insurance, and Medicare was never designed to cover long-term care. If you haven't talked to your financial planner, you probably should. It would be good to at least know what that landscape looks like. In a world of partial sentences and half-truths and floating asterisks, there's an asterisk. And what that is there's a qualification. As good as that benefit is, you need a qualifying stay in the hospital to get that skilled nursing facility. You need to be admitted for 3 nights. You learned that one, right? So the 3 nights admission, you can easily spend the night in the hospital under observational status. That's different. There's not a diagnosis. What we need is a diagnosis and the admission, because we're going to find it and we're going to fix it. It takes 3 nights being admitted to get this skilled nursing benefit. We've seen people who've been in the hospital for 4 nights only to get burned when they went to skilled nursing because 2 nights were observational, 2 nights were admitted. This is an important lesson to learn in any kind of health insurance. Doc, what are we doing? Why are we doing it? What are my alternatives and who's paying for it? Let's be clear about the rules of engagement. Home health services, wonderful benefit. We'll send a medical professional right to your front door. But by definition, that's very limited. They're coming over for wound dressing or a handful of physical therapy visits. They're not sticking around long. Their job is to get you back on your feet, out the door to seeing doctors where they're less expensive. And hospice, I put down 5% for medications. Medicare picks up almost everything, but there can be a copayment for the medications you take before you expire. There's no premium usually for most people, but in this instance, there's exposure. That's what we want to know about. What are you responsible for if all you have is original Medicare? Go to Part B. If there's one word for Part B, it's services. A is all the buildings. B is everything that goes on in the buildings. All of the doctors that you see, all of the specialists that you see, whether it was in the hospital or in the office, they're billing up under B. All of your lab work, everything from a blood test to a biopsy, all of your diagnostic testing, that's the expensive alphabet soup, EKG, EEG, MRI, CAT scan, X-ray, all of those things coming up under B. Durable medical equipment. That could be as innocent as a walker or a wheelchair. It could be as expensive as a pacemaker, a COPD machine, or an insulin pump. The new knee that you got, the cataract lens, that's all DME. If you've ever had a joint replaced, you know that PT stands for pain and torture. These are professionals that are going to hurt you and get you back into shape. Medicare pays for physical therapy, the ambulance taking us to the emergency room. Your outpatient services, that's basically anything surgical that didn't have you spending the night in the hospital. And this has gotten to be crazy. Stuff that would have kept our parents in the hospital for days, they're doing in hours. Shoulders, knees, hips, that's old. I had a client 2 months ago had heart ablation. I don't know what heart ablation is, but it sounds expensive. He was in the morning, out that afternoon. The ticket on that was over $250,000. They did it in a day. But that's building up under outpatient. And the last part of B is clinical RX. That would be medications that are delivered in an outpatient setting, a doctor's office or the hospital. Think about god awful. This is chemotherapy, kidney dialysis, radiation treatment, terrible things. But if that is delivered in a medical setting, it's gonna bill up under Medicare Part B. And when we start talking drug programs, you're gonna see how important it is to make a fully informed decision when it comes to medications. Because in the drug programs, we have something called the donut hole or the coverage gap. That can be avoided if you have meds that are instead delivered and infused into you. That's usually pretty catastrophic stuff, but it's important to know. A and B is structured differently. A kind of has a pay-as-you-go mentality, do this, pay that, do this, pay that. B, on the other hand, has an overall annual deductible that's followed by cost sharing. That deductible this year is insane. It's insane every year, but if you understand the world of healthcare, if you understand your employer plan, if you understand what's going on in the Affordable Care Act, the deductibles are thousands of dollars, followed by co-insurance, which can also be thousands of dollars. Here with original Medicare under Part B, you have an annual one-time deductible of $226. That $226, I don't think you could find a doctor for $226. I don't think you could find a blood panel that retails for under $300. The first $226 is on you. After that, Medicare steps in and they start splitting bills with you. They pick up 80 cents on the dollar. They hold you responsible for 20 cents on the dollar. This is a wonderful benefit, but also understand on this field of play that 20% has no stopping point. Your employer coverage has what's called a maximum out of pocket. That's where it all goes wrong. And you need major stuff. There's a deductible usually followed by co-insurance, but there's a stopping point out there someplace. On most employer plans, that could be $3,000 or $4,000 or $5,000. It could be even more in the under 65 independent market. Lori and I are both on plans. We each pay $1,000 a month to each carry a $7,000 deductible. To look at $226 blows my mind.
Same here, we are paying $2,200, my husband, myself, per month for insurance.
You bet. And that's
our
not the
deduct-
worst part.
And our deductible for each one of us is $7,000.
There you go.
And nothing,
And this is what they call the Affordable Care Act. I'm not
it's just
making it
like,
up.
I'm like, it's buying a big house and living in there, it's just draining us. It's just killing us.
And yet, the cornerstone of any insurance is the what if, it's the scare factor. So we carry insurance just to know that we're not wiped out. I promise you, if you get anywhere near this Medicare thing, you're gonna light up like a Christmas tree, because this is wonderful coverage. Even this 80-20 split, it's even better than that because Medicare is taking their negotiated discount. Once you've paid the $226, Medicare steps in and they start negotiating these bills. And if you've ever seen a Medicare bill, it'll blow your mind because the cardiologist says, I'm brilliant, I charge $350. Medicare says, you're adorable, we pay $80. On the 80, you're responsible for 20% of the 80. We literally see doctor visits coming through at $12, $15, $16 based upon the base of Medicare. A and B forming the foundation, A and B really good, A and B not complete. Hit the slide, but it's pretty darn good. When you think of what you're getting for $164.90, if you're not making bank, right? $164.90, that's an amazing value. And you would know, because I would know, you'd look at that and you'd say, wow, how do they do that for $164.90? They don't. They're dropping north of $1,000 a month on each of us. They ask you for the $164.90. They ask the well-to-do to pony up a lot more. They keep raising the taxes. That's how they're feeding the beast. That money that they're actually spending, remember that number, because when we talk about Advantage and we talk about these zero premium plans, how can they do it for zero? The government is transferring a lot of the money that they would normally be spending here over here to a private insurance company. A and B good, but not complete. Now what are we gonna do? We're standing at the crossroads. I've got my A and B. Maybe that's when you turn 65, or maybe that's when you turn 72 and decided to roll off of your creditable coverage. Here we are, and we're gonna look at two pathways. One pathway called Original Medicare. A and B good. On this pathway, it's a tectonic shift. You're moving from an under 65 world to an over 65 world. This is different. Understand on this side of the equation, what happens, Medicare is moving into primary position. Medicare is the negotiator. Medicare is the network. Medicare is doing all the billing. Medicare is doing all the paperwork. But we saw that A and B good, but not complete. They're going to send the leftovers. You can pick up secondary coverage from a private insurance company that can step in and pick up some or all of those leftovers. These supplements have to play by Medicare rules. Medicare says what's going on in this field of play. The new sheriff in town is Medicare. They're watching the companies, they're watching the agents, they're looking out for you. They believe in full disclosure, robust competition, and complete transparency. I'm here to tell you capitalism works, but it only works if you keep it on the rails. These supplements that you would be looking at, it's a different world. Medicare primary is going to shake you up a little bit because you're coming from an under 65 world and you've been drilled through the years. You've got Humana or Blue Cross or Aetna or United Healthcare. I don't care. Whatever your network is, you've got to stay in network. You can't go out of network. You've got to see your doctors that are in network, because if you go out of network, you're going to get clobbered with out of network charges if they cover it at all. Under 65 is network, network, network. You come to Medicare and you're like, okay, so what's my network with original Medicare? Any doctor, any hospital, anywhere in the United States, they take Medicare, you're in. You could not have a more robust PPO. You're in Key West or Grand Tetons, as long as they take Medicare, you're in. That's your primary coverage. That's your network. That's the one that's stepping into primary position. Good, but not complete. And now here come private insurance companies.
Just a quick question. You say anybody who accepts Medicare,
Correct?
but that's anybody. It's
No,
not
no.
a lot.
There are doctors that do not take any kind of insurance. They're called concierge doctors. They'll charge you $3,000-4,000 a year, but they'll see you on Sunday at 3:15 to do a 2-hour physical. But you're paying them. They're off the grid. They don't even take insurance.
No, I'm not worried about that part. I'm just worried, like you say anywhere, whoever accepts Medicare.
Correct.
you're in.
That's the
But
key.
is it a very large network?
99.1% of all physicians in the United
Okay.
States.
No,
take
I just
Medicare.
wanted to hear
Yeah.
that.
Good
Yeah,
question.
that's it.
Okay.
And so I think what you're seeing too is there are instances where physicians take Medicare, but they may not be taking any more new Medicare patients. So that might be also part of the perception. It's not that they don't take Medicare, but they're full of a bunch of old people, because
Okay.
13,000 of you are turning 65 every day.
No, my precise question is, if I wanted to go to Mayo Clinic, Cleveland Clinic, University Chicago,
Yep.
one of these facilities,
Yep.
because I need to go there.
Yep.
That's all I'm worried about. I don't care about anybody else.
Well, okay.
Because my ailment is pretty peculiar and I need to see a specialist for that. And these are the places
got-
where they are.
I got a program for you. It's called Original Medicare. And every one of those hospitals you listed are in Original Medicare.
That's all.
Good, but not complete. What are we gonna do about the leftovers? We're gonna look to a secondary package of coverage to make it complete. The beauty of these packages is Medicare is telling them how they're going to present them, not the insurance companies. If you've ever shopped insurance in the under 65 individual market, it's virtually impossible to make a direct comparison. Humana uses different language. Blue Cross has a different network. United Healthcare has different co-payments. Aetna has a different color. It's a nut job trying to figure out under 65 where to go. Medicare says, gentlemen, we are not going to play the game that way. We're going to play the game this way. Medicare has standardized the delivery of 10 packages of benefits. Medicare has base benefits, that's what we just talked about, and then 10 levels of coverage that you get to choose what's appropriate for your situation. These packages of benefits represent different levels of coverage. You want the penthouse? We got the penthouse. You okay with the pup tent? We got the pup tent and everything in between. But understand the rules of engagement. If you were to look at N as an example, a package of benefits, but Medicare says what N is, not the insurance companies. Wait a second. Are you telling me that N from Blue Cross Blue Shield would be similar to N from Mutual of Omaha? No, it's not similar. It's identical. Medicare says what N is, not the insurance companies. Okay, but wait a second. I'm not so sure about this. I know my doctor takes Blue Cross Blue Shield, but does my doctor even take Mutual of Omaha? No, sir. Does your doctor take Medicare? Medicare is primary, Medicare is the network, Medicare is doing the billing, Medicare doesn't pay anything. And they send it to secondary coverage, which can pick up some or all of those leftovers. These packages of benefits standardized by Medicare. Currently, we have 44 companies that are offering Medicare supplements, beating each other over the head, trying to win your business, understanding that you can see all the prices that are out there. If you look at this field of play, you'd see that three traditionally have driven our conversation. It would be the F package, the G package, and the N package. That's a good cross-reference to look at. This would represent historically about 90% of all supplements would fall into one of those three buckets. Look at F, very popular and really the granddaddy of them all. F, so comprehensive that it wipes out all exposure. No 1,600 in the hospital, no 200 in the skilled nursing, no hospice copayment, no 20%, and it even pays the $226 annual deductible. So comprehensive that it's really expensive, okay? What would you think about an insurance program that had no deductible? I know how insurance companies work. The more you want them to do, they're happy to do it, but the more they do, the more they charge. And it never took long to see that F was not a good value. G was a superior value and continues to be to this very day. Very similar coverage. Wait, there's an empty box there. You're gonna reach into your pocket and pay for something. F pays for it. What is it? It's the Part B deductible. Right, $226 in that box. That's your annual deductible. Once you've paid that deductible, G steps in and picks up everything that's a Medicare approved charge from a doctor or hospital that accepts Medicare 100%. Look at the math. If you look at the F and you compare it to G, I've got 44 companies that are offering you both in virtually every instance. That F is at least $50 more per month than the G. So wait a second, where's my calculator? I took the F because the agent said it was the best coverage I could get. Well, that's a kind of nebulous term. What do you mean by the best? Is it the most comprehensive? Yeah, it's the most comprehensive because it's the most expensive. But let's look for value. The G is $50 less per month. That's $600 less per year. So what you're telling me is I'm paying $600 more per year for the F. And what's the one additional benefit I'm getting for my $600? They're paying the $226. That don't make sense at all.
Yes.
You pay the $226 and pocket the difference. That's called the deductible, and insurance companies love it when you participate. That's all insurance has ever been, is a sharing of risk.
Of course, you can't really get F anymore.
You can get F if you turn 65 before January 1st of 2020.
Right.
It's still in the market. It's still available to this day, and there's still agents trying to convince people that that's a great value. F is for foolish. It's way overpriced for what it does. Understand a sharing of risk. With the deductible, you've driven down premiums. Maybe you're healthy. Maybe you understand this sharing of risk, and maybe you might even think of maybe the N, which is growing in popularity. N says that not only will you pay the Part B deductible, but you also, after that, agree to doctor co-payments. Down here at the bottom, $20 to see a primary, $20 to see a specialist, and $50 if you go to the emergency room and they send you home. That's very negligible exposure. But what that's going to do is drive down your premiums because you're reaching deeper into your pocket. Insurance companies like that. The N compared to the G, if I look at a couple turning 65, just as a generality, I'm going to see that the G is more expensive. Of course it is, because it doesn't have co-payments. I'm going to see the N is less expensive because it has co-payments. But if I look at the difference between those two programs and I divide the difference in savings by those doctor visits, I'm going to show you that that couple is probably going to need to be going to the doctor more than 25 times a year for him to have been a bad choice. Based upon your needs, based upon value, please.
Can you switch back and forth between these plans? Or once you're in, you're in?
Yes, you can, asterisk.
Okay.
Medicare has 3 base rules. When you first come to Medicare and you activate your Part B, rule number 1, you have the ability to go to any of the companies that offer any of these products, and you are guaranteed no underwriting, no pre-existing conditions, nothing. But that's a limited window. We call it your golden ticket. In that window, you can go to any company that offers these products. And furthermore, rule number 2, they can never drop you. You're theirs and they're yours till the day you die. And most importantly, they can never single you out for a rate increase. Your claims are shared based upon everyone that's in your risk pool. If you look at N and you decided to do N with AARP, I got no dog in the fight. We represent all these companies, but you would go into a pool with everyone that's got N from AARP. You could have a terrible year. First diagnosis, dread disease, snake bite, car wreck, fall off the roof, stroke out. They can't come to you and say, man, you were really expensive. We're going to raise your rates. No, your claims are shared by everyone that's in your pool. Huge pools have modest rate increases. Small pools are very volatile because they're sharing claims over a very small group of people. We talked about the window of enrollment on these. You've got your golden ticket. What is that? That's 1 year that surrounds your Part B activation date. 6 months before you activate B, 6 months after you activate B, go anywhere you want to go. They gotta take you, they can never drop you, and they can't single you out for a rate increase. But that's a limited window. Then what happens? Eventually 6 months passes away, and then what happens? Now, you can change these every month of the year. Common misconception that we got to wait for the annual election period to change your supplement. No, you can change your supplement every month of the year now, but now they can ask you medical questions. And they can say, wait a second, you've got pre-existing conditions. We had to take you in that 1 year golden ticket, but now you're out here. We don't have to take you. If your health is good, everybody wants you. But if your health is dodgy, you're going to find that 43 out of 44 companies are going to ask you medical questions and can decline to cover them. But in Illinois, there's one company out of 44 that we have that does not ask medical questions. That gives us the ability to move people that we meet in their 70s or 80s. They might have taken F initially because the agent said it was the best coverage you could possibly get. It was the best coverage the agent could possibly sell you because it's the most expensive. It pays the highest commissions. It's not your best value. But now at 85, that F is starting to go up. Think about the risk pool of F. There's nobody new coming there. They stopped that January 1st of 2020. If you turn 65 after January 1st of 2020, the government finally agreed with us that F was for foolish. They're not selling that to new people anymore. What does that mean about your risk pool? It's getting smaller and older and sicker and smaller and sicker and older, and you are sharing claims with an ever diminishing group of people that are filing more claims. Those rates have really started to jump up. And that's why we say F is for foolish, but we can get you out. Even if you're 85 and you got COPD, we got a company that would let you move to G without underwriting or even N. Please.
But if you have F right now, let's say Blue Cross and Blue Shield, and you have pre-existing conditions now in your life, and you want to stay with Blue Cross Blue
They
Shield.
can never drop you.
Oh, so in other words, I could go from F to G without having to take a physical and all that?
Because there's only one company that does not ask medical underwriting questions and would allow you to make that move.
And that is Blue Cross Blue Shield?
Thank you very much. I'm not here shilling for anyone.
I'm just-
I'm not even supposed to
So I
mention.
don't-
it.
I just-
If I don't.
But that's what I-
And then it's telling me I say 200, well, I say, you're saying 600, but really you're paying the 200 and some odd dollar deductible, so you're not saving 600, you're saving more like.
Go ahead, be a killjoy.
But I'm,
We don't want to say $450.
yeah,
Okay,
yeah,
then I would be on the phone, and I'd be on the phone with them tomorrow,
yeah.
and I'd be saying, hey, I think I'd like to move from the F to the G. And they would do that as of November 1st without underwriting.
Okay,
Check those rates. They got 2 books of business, not promising you the world, but I'm saying it's certainly worth taking a look at. F is overpriced for what it's doing, and it's getting more expensive more rapidly. Who would take G? Because now G is the top shelf, it's the big. Who would take G? Well, usually, I'm not picking on G people, but I'm just saying people who take G are typically in a risk pool, and they're surrounded by people who have medical issues. Maybe they're waiting for a knee replacement, or they had some sort of major medical event in their lives, or they've got storm clouds on the horizon. Generally speaking, the G group of people are utilizing more services. That's why they took G. It's the greatest sleeping pill money can buy. Pay the $226 and everything's covered. But who takes N? Well, who takes an insurance product that's got co-payments? Somebody who's not afraid of co-payments. Who's not afraid of co-payments? Healthier people, generally speaking. Major player just this year came through with their rate increases. Their Gs went up 5%. That's totally reputable. That's a really good number. A 5% increase for the year, very good. Their Ns went up 2%. 3%, is it much? Really, is it? Well, you're starting with a bigger base on the G and it's going up faster than the ones that got the lower and going up slower. We see that spread between G and N getting bigger as the years go by. If prudently you don't go to the doctor a lot, I'd sure like to show you how the N works. It might not be your cup of tea, but understanding it's not just F, 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 different horses for different courses based upon your needs, and a prudent assessment of those needs has the ability to make these changes. Questions on supplements, questions on supplements. Very good, please.
I'm just gonna point out too, I think with traditional Medicare, you can go directly to a specialist. But with the advantage, you have to go to your doctor to authorize it.
Some Advantage programs, you are correct. If it's an HMO, you need a referral, but if it's a PPO, you don't, and we'll get there, I promise. But yes, the beauty of Medicare, any doctor, any hospital, anywhere in the United States that accepts Medicare, you don't need a referral. You don't need to wait. The doctor says you need an MRI. Okay, if they're full, I'll go there, I'll go there. But the fool's errand here, the problem is we see people that get tripped up because they're too cute by half. If N is N and everybody's doing the same thing and Medicare's the network, I got this figured out. I'm just gonna go online and I'm gonna find the cheapest price for N. And maybe it's a shady company. That's not gonna worry me because I know every year I can change my supplement during the annual election period, guaranteed, right? Wrong. These have different timing patterns than the drug programs. People will find themselves going with the lowest bidder, and I've seen this time and again. I can show you the graveyard. The big companies that we prefer to represent, A+ rated, been in the market for decades, very strong players. We show you their rate increases. They'll be here, but I promise you right now, there's 3 or 4 companies that are less expensive. They're small, they're trying to get a foothold. They're paying a broker bonus if I can talk you into going with them. But I also know within 2 years, these guys go up, these guys will go up. Because with a small risk pool, all it takes is one lung transplant and everybody's rates go through the roof. These smaller companies are alluring you with a sharp rate, but do they have legs? I want to look at all of them, but I want to show you the ones that are A+ rated, been in the market for decades, have the best track record on minimal rate increases. That's where you want to place the business. That's where we want to place the business, okay? Questions on supplements? You with me so far? Let's keep going. Hit it, Laura. Please.
Well, I think it all starts, you have to have the A and B.
I'm sure we just said that.
With everything else, it's not like you can reduce your A and B costs. If you have high A and B costs because of Part A, that's the minimum you're gonna have to pay.
I said at least 6 times, gotta have A and B to do anything else.
Yeah.
Once you got A and B and you understand that it's not complete, how are you gonna make it complete? A and B is between you and the federal government.
Yes.
We're not the federal government. We're the guys that sell all this other stuff to make it complete, to help you sleep well at night. This is between you and the folks at Social Security. Can't do nothing. I can cheer you on from the sidelines. I can show you the forms. I can show you where to go to turn them in. But that's between you and the feds. Good, but not complete. You've got to have A and B to do anything else. We're going to talk about this Advantage thing, and somebody's going to say, great, do I still have to have A and B? Yes, you must have A and B to do anything else. Clear?
Yeah.
Good. So the supplements are going to help us defray the exposure that we have with A and B, but now we're going to want a drug program. We're going to make this package complete. We're going to go to all 3 pieces, and with the drug program, Medicare is there again running the show. Hit it. With Part D, understand you don't have to take a drug program. Government doesn't force you to take a drug program, but they want you to take a drug program. If you don't, they're not going to worry. They're going to wait for you. And somewhere down the road, you're probably going to decide you want a drug program. We had a woman last year, her son reached out to us. She's 90 and never took a drug program. Actually, her husband never took a drug program. That was his mistake, but he checked out about 15 years ago. She's 90 And now the doctor says, I need you to start taking this med. It's called Eliquis. It's a blood thinner. It's a miracle drug. It's $600 a month.
More now, it's $885.
Depends on the carrier. We've seen it as low as in the 500s, but it depends.
And I'm talking about if you have no insurance and you go to a drugstore, because I know some who needed it, and it was $885.
There you go. Do you need good
And
RX?
they give ads for.
GoodRx brought it down to 500 and something, but it was still out of touch for most people.
I agree completely.
Yeah.
So the idea that she needs that Eliquis and she needs it every single month, not to worry, we can rescue her. We can get her during the annual election period from October 15th to December 7th. We have the ability to sign her up, even though she didn't have prior coverage. The drug programs are guaranteed to be able to be rewritten or written for the first time. So we get her into a wonderful drug program. And the problem is she wasn't thinking of the late enrollment penalty. It's negligible. It's about 35 cents per month, every month, every month, every year, every month. And here she is at 90 now, never took the drug program. And for 25 years, she didn't have a drug program. 35 cents a
It's not a
month is about $4 a year. 25 years, that's $100 penalty that she's paying every month now. It's not a one-time penalty, it's in perpetuity.
And we send a big love letter, you know, saying that if you don't have this, there will be a penalty. So I saved that just to ask you guys, what is this? And you just.
If you don't have creditable coverage and you swerve outside of that window, remember 3 months before your birth month, 3 months after, you need to get a drug program. If you don't, you could start accruing a penalty. It's negligible, but it adds up over time, and it's a bitter part of helping her. But now we're gonna help her. We're gonna get her, she's gonna pay the late enrollment, she's gonna be in this annual election period, she's gonna start January 1st, and that's gonna be great. And we're gonna save her some money, but you also need to understand how the drug programs work. Currently, we've got 24 drug programs. They don't all cover the same stuff. What would be the point? Some are all generic, some are all brands, some are a mixture, but all of these drug programs are gonna have different menus of drugs, different formularies. These formularies will be broken up by the drugs that you take. Tier 1 drugs, very inexpensive generics. These are the things that most people are taking: amlodipine, metformin, atorvastatin, any number of drugs that are tier 1. They're preferred because they've been around forever and the co-payments are very low. Tier 2, these are newer generics, things like rosuvastatin calcium is the generic for Crestor that recently came out. It's got a higher co-payment because it's newer. Tier 3 drugs, these are drugs that are advertised on TV. Tier 4 drugs, these are advertised by famous people on TV. And a higher co-payment because they're newer, they're non-preferred. Specialty drugs, these are drugs that you don't even want to consider. AIDS medications, anti-rejection drugs for transplants, chemotherapy that you could take in the privacy of your own home. Really, there is such, there is. There's a pill that you can take in the privacy of your own home. It's a beautiful thing. But dude, it is expensive. That's very important because if we're making fully informed decisions, we might want to ask the doctor, if I came to the office every couple of weeks and got infused, that's going to bill up under Part B. If you get it through your prescription drug program, pick it up at Walgreens, it's going to bill up under Part D. Why is that important? Because the drug programs all have 3 stages of coverage. That's on the 3rd page of your handout. These 3 stages of coverage are true in every drug program, whether it was an Advantage program or whether it was a standalone drug program. You move through these stages of coverage, not based on your co-payments, but based on the retail value of the drugs that you're taking. How does that work? Well, my 90-year-old got her drug program. She was very excited, and she encounters this new landscape that's developed by the government. This is how drug programs are built. They're built trying to get you to use generic drugs wherever possible, which we normally would do, but there are miracle drugs, and Eliquis is one of them. Call it $600. You say 8, you say 5, I'm gonna say it's 6. Well, her first Eliquis, the drug program that she's in, has a deductible. And most of the drug programs do have a deductible. This year, about 80% of them had a deductible, and the average was usually $505, was the Medicare standard. When she goes for her $600 Eliquis, First Eliquis is gonna hurt. She's gonna knock out the deductible. But then thank goodness January is over and she's in the initial stage of coverage and life is pretty good. The drug program she's in actually charging $47 a month for that Eliquis. That's a deal. But understand, they aren't tracking what she spends. They're tracking the retail value of the drug. She says 47, they say 600. She says 47, they say 600. She says 47, they say 600 until she hits a breaking point, a threshold. This year, that threshold, $4,660 worth of drugs, not what she spent, but the value of the drugs she has acquired. If she breaks through that at $600 a month, what would that take? 7-8 months. In about the 8th month, she's gonna cross over that threshold and fall into the coverage gap, the donut hole. The donut hole, she's still protected, let's not panic completely, but now she's got a much higher percentage of participation. She's now paying 25% of the retail value of the drug. She's gone from 47 a month to 25% of 600 is $150 a month. That's called the coverage gap. That's called the donut hole. That's why we've got to research these programs every year to see that coming. Got to be very careful. How do we do that? We can research every drug program by calling them, or we can go to Medicare.gov. Question.
I have a question. You put me into a great program this past year. Thank
My
you.
sister, she shows up at every one of these.
Did that, but what happened was because my medications are so expensive,
Mhm.
the insulin, things like that, I was in coverage gap like by Aprilish.
It's easy to do. If all you're taking is generics, it's really tough to fall into the
But then
coverage.
I was into catastrophic right at the next month. So sometimes you can get into catastrophic quickly and then all your stuff prices.
And
go down.
next year, where this year catastrophic, you were responsible for 5% of the retail value.
Uh-huh.
This next year, it'll be 0. So as you get to that catastrophic stage, that could be something that will be beneficial to you, but it's still gonna be very expensive back one, moving through these stages of coverage. What she's explaining is that you can get out of the coverage gap, but the way you get out of the coverage gap is by hitting a very big number.
Right.
That number is the combination, I know it's weird, but it's an algebraic equation, what you spent in this stage, 47, 47, 47, plus the retail value of your brand name drugs here. Only in America do they call it the total out of pocket is not really 7,400, because that's an inflated number. They're counting retails in there when you're in the donut hole. That's what propelled you into this third stage called catastrophic. This year, that's actually going down to 0.
So I'm just
And-
gonna wait for you guys to take a look at my stuff.
We have people that are on god awful meds. I mean, there's miracles out there. If you know Humira or Enbrel, these are really expensive meds. You got the guy on TV, you've seen the Skyrizi guy with the red arm, right? And now he takes Skyrizi so he can wear t-shirts and show off his arm. He's not embarrassed anymore. That's like $15,000 a month.
Wow.
It's insane. He's propelled right through these stages into catastrophic on the backside. So you move through stages based upon the retail value of your drug. We want to see this coming. How are we going to do that? We're going to go to Medicare.gov and we're going to run this report right here. And the federal government forces every drug program next year to show you exactly what they're going to charge you. It would be insanity if you tried to look at it in all coverage stages, although you can. But what they do is they add up all those stages into one single number that we can compare, and then it ranks it from first to worst, least expensive to most expensive. It's a wonderful tool. This is a guy we ran at the beginning of this year. His plan premium is $25. It's reasonable, about mid-range. His preferred pharmacy is CVS. Be aware who your preferred pharmacy is. That's the strategic partner for your plan. People will pick the right plan and go to the wrong retailer. They'll spend way too much. You want to make sure you're getting premium value by being a preferred network. Used to be mail order was always your best option. Not anymore. The retailers have figured out this is a hell of a way to get people into the store. So they're undercutting prices because they know when you're at the store, you're probably going to pick up something along the way. Here's his dreaded Eliquis. They're retailing that this year at $523, but he only pays $523 until he enters the coverage gap in August. And once he enters the coverage gap, that 47 now goes to $130. We gotta see this coming 8 lanes wide. Please don't be surprised by this. I'm stunned this year, every year. October, November, we get a lot of phone calls. People get referred to us. We didn't work with them initially. But my friend said I should talk to you. What's going on? Well, I've been going to Walgreens every month and I've been buying my drugs and my drugs have been $77. And now I went to pick up my meds and all of a sudden now they want way more. What's going on? I said, well, it sounds to me like you might have fallen into the coverage gap. No, I can't have fallen into the coverage gap because I've only spent $700. No, sir, it's not what you spent. It's the retail value of the meds that you've acquired. People who don't understand this are in jeopardy. Knowledge is power. Understanding how to shop, understanding that if you don't do this at Medicare.gov, call 1-800-Medicare. Find a shift counselor. These are volunteers that will help you. We work with our clients every year trying to make sure they're in the best possible programs. Supplements traditionally are like ocean liners. They will be steady for years to come. It's the drug programs that are like speedboats. It's unusual that we aren't changing the client at least every 3-4 years. 1, their meds might have changed. 2, the meds might have changed themselves. I was talking with a gentleman just a week ago. He's in a $103 drug program. Ooh, that sounds really, really nasty. What all are you taking? And he rattled them off. And he hadn't looked at the drug program for 8 years. And I know what happened. 8 years ago, he took the $40 drug program because he was taking 2 brand name drugs. And every year that went up and every year that went up. And now 8 years later, it's $103 a month. And those 2 brand name drugs have gone generic. He has missed the boat completely. He did not need a $103 drug program this year. He would have done better in the $8 program. You save somebody $92 a month, that has a tendency to get their attention. It's a good thing. Questions on drug programs? Please.
Go ahead.
Okay, on any of these programs, supplemental or like the drug program, you're saying he missed the boat, but don't you have to renew the
No,
drug program?
no, everything,
You don't
will-
renew
you don't
because-
need to do anything.
Okay.
And that's a problem because people will make one decision, they'll throw it in the kitchen drawer and they never look at it again. That's a
Is that
critical
the same
area.
with supplemental?
Yes.
Yep, supplementals are much more steady because the benefits never change. The pricing will change, but G always says, pay the Part B deductible and then you're covered. Those are on a different time frame. Those are from private insurance companies. Those, you get that golden ticket and it's important to take a look at that. But your supplements will remain steady. If you go with a major player, a solid company in our estimation, they'll stay steady for years to come.
So when they
And
talk about open enrollment and all that, that's for new people. Once you have a plan, if you choose not to change anything,
it rolls over.
it just rolls over.
Yeah, so forget about it. Just put it in the drawer. Don't take a look at it. And 8 years later, you'll be the guy that's paying
Well, no,
$103.
it'd be more profitable to sit there every year and go over, correct?
There's a fundamental difference between what you knew for 64 years of your life with employer coverage. With employer coverage, every year, even if you wanted to keep the same thing, you had to re-enroll. That's what
Yeah.
open enrollment was with employer coverage. In the world of Medicare, you never have to re-enroll in anything. If you want to stay with what you have, you do nothing, and it will automatically roll over into the next year.
Which
That's the
drives
biggest
us,
difference.
drives us insane because the advertisers know where you come from. You come from the world of under 65.
Yes.
For however many years, you've had to readdress your coverage. And the ads will say, there have been big changes to Medicare.
Yes.
No, they haven't. Your coverage is in jeopardy. It may be ending. No, it's not.
Yeah.
Dial the 1-800 number and let our guys get their claws into you. That's what they're doing. They're trying to tempt back on these unsolicited calls, these call centers, where you call to get all the benefits you're entitled to. Those are all sales sites. And it used to be Joe Namath, and it used to be the big giant Medicare card, the Medicare card. And it said Medicare Benefits Hotline. Who am I calling? Obviously, I'm calling Medicare. No, you're not. You're calling some guy in Florida who doesn't quite fully understand what's going on in Illinois, but maybe that phone's ringing because of dental vision here and get all of that. They've started really to tamp back on that, and it's good for the consumers. But your point taken, you don't do nothing, it rolls over. And maybe for a year or two, that's okay, but inevitably, we wind up finding couples that have been in this side of the equation, hit it. This three-pronged attack where you've got Medicare A and B.
This is stuck. It's not doing what you want it to do. Sorry.
It's happened before in my life, I must admit. The idea that original Medicare has three parts to your coverage, A and B, not complete, add a drug program and a supplement, these three pieces acting in concert. And this is where most people are gonna start. What you find is that these premiums initially are very reasonable, but it's also not unusual that 7, 8, 9 years down the road, Dad seems to be sitting at the kitchen table saying, you know, baby, when we signed up for this originally, it was pretty reasonable, but now, 8 years later, between your supplement and your drug program, we're dropping $250 a month. And between my supplement and my drug program, we're dropping another $250 a month. That's $500 a month. And as far as I can tell from the explanation of benefits, we went to the doctor a total of 7 times last year. Is that value? $6,000 for 7 doctor visits? I'm not sure. Maybe we get a shot at them. Maybe we can educate them. Maybe we can find out, you know, I know you guys took the F and I'm sorry, it served you well, but now the F is getting out of hand. We have the ability to move you to the G or move you to the N. We've got a company that doesn't ask medical questions. That gives us wonderful liberty. You took the drug program 8 years ago and you've never looked at it since. That's a big problem. I know it rolls over automatically. I also know most of them go up every year, and I know the formularies are changing. Your needs change, the drugs change. One company maybe have your drug as a tier 3 this year. Next year, they have it as a tier 4.
Yeah.
Next year, they don't cover it at all. That's why that annual notice of change is critically important. You want to look at that and see what the changes are. The company's got to tell you what they're doing. But this idea of paying $6,000 a month, $6,000 a year for this coverage, we move them from the F to the G. We change their drug program. We can tune it up. We can make it better and probably save them $200-300 a month. It's not unusual that that will happen. And it's always a really good feeling, but it's always mom that seems to want to know, how long could we have been saving $200 a month? Years. You just missed it completely. Stay in touch, please.
You know, I think people though have to focus on, when you analyze this, you go, okay, I only went to the doctor 7 times during the whole year. I only take 2 drugs and they're generics now. How do you know you won't get cancer tomorrow?
You
Or
are,
a massive heart attack?
you are what the insurance companies are founded on. What if?
Well, yeah.
What if? What if?
Mhm.
Drives me crazy.
But it's true.
It is true, but every
Yeah.
year you have a chance to change. Every year your drug program you can change. You can
Mhm.
change your supplement every month of the year. You've got these things called advantage programs that you could look at too. You're not handcuffed. But my experience in the insurance industry is frustrating because I know the cornerstone of insurance scared the bejesus out of people and
Yes.
load them up while you got the chance. They're really pliable if you can scare them. It's never been our speed. Drives me crazy. People
So who
overbuy here, people have been overinsured here for years.
So who buys the Medicare Advantage plan? What is the benefit of?
That's my sister, ladies and gentlemen. Thank you for coming. Advantage is a different idea. Please.
And you're showing the other loop, the loop for this,
Can you back it
Part
up?
B and the supplement, that's all private companies, right?
Correct.
Okay, so only A and B you get directly from Medicare.
And you gotta have A and B from the federal government, forming the foundation, good but not complete. Add one of 24 different drug programs. What's the best one for you? Because I'm almost sure it's not the same that's the best one for him. The problem here is people will make decisions based upon what their neighbor did. Really? Your neighbor may have chosen brilliantly for them, but it might be the totally wrong program for you. And it's not unusual at all that on the drug programs, mom's meds are different than dad's meds. Remember, we can customize it individually. That's what you want to look at, not a blanket statement. We'll see people that have done everything with the same company. It can happen, but usually not. Usually, there are certain companies that their sweet spot is the drug program. There are other companies where their sweet spot is the supplement. We want to take the best of the best and the best of the best and put it together, both for husband and wife. And yes, these are private insurance companies.
How do they keep track, you know, with the penalty? Because they want to encourage you, right when you're 65, to do it so you don't have penalties.
We have people for that.
So even if you're changing companies, They keep track that you've had it the whole time.
You bet, you bet. And when you show up at 72 and you decide now you want to activate your Part B, you're not just going to turn it on. You have to provide documentation that you've had creditable coverage since you turned 65, or there can be penalties. There can be lockouts. There can be have to pay.
So who keeps track of it? If you're going with Part D and the supplement from a private company, does Medicare keep track that you've had it?
Government is tracking your Part D. They know you enroll in a Part D this year, it's going to kick out the Part D that you had. So the Part D, the government's running that. Private insurance companies run the supplementals, and they'll hit you with advice statements on a regular basis.
Okay, so it's all kept, so as long as you keep it in coverage, you have no penalty.
Correct,
And that's all
okay?
kept track.
So we're not gonna think about maybe here, maybe we think about another alternative called Medicare Advantage. This is a different idea. Remember, we said here, Medicare is good, but it's not complete. It's got unlimited exposure. That's why we wanted to add additional stuff so that we could sleep at night. 24 companies here, 44 companies here, customization. You're paying a premium and you're paying a premium to sleep well at night, to know once you've spent your 226 or whatever that is, you're completely covered. But there's this idea of a private health insurance alternative called Advantage. It's one pathway or the other. You don't do both. You do one for a year and then you have an ability to reassess. But this Advantage program is intriguing to this company, this couple here rather, because they're going to spend $6,000 next year if they make no changes. They just let it sit in the drawer. They're not going to look at it. They're all the same. No, they're not. They all go up every year. No, they don't. I couldn't qualify. Yes, you could. We know the most terrifying word that seniors can hear is change. God, they hate that word. So they become complacent. And they just let it roll over because it's just easier that way. But eventually, you'll find our way to our table because the price of the stuff will keep getting more and more expensive. Maybe this couple, instead of spending $6,000, they decide to try an Advantage program. Different idea, different rules of engagement. This is now a private insurance company. So number one, you want to know it's got more limited networks. It's not any doctor, any hospital that takes Medicare. It's the network of the insurance company that you're going with. And there's currently 53 Advantage programs available in DuPage County. Crazy competitive, all trying to win your business. They will all have restricted networks, but I assure you, the AARP network is different than the Blue Cross network and the Aetna and the Humana and the Cigna and the WellCare. Oh my gosh, we could probably find your doctors, but this would be the most important first question of an Advantage program is, how are you doing? If you're not doing particularly well, you might not want to go to a platform where you've got co-payments for all of your services. The other thing we want to know is, are your doctors in network? Because these Advantage programs, also known as Part C for complete, are restricted in their networks. They will all have co-payments for services, and you move from, remember the G supplement, annual deductible of $226. Once you've met that 226, it's Katie bar the door. MRI, CAT scan, X-ray, iron, lung, kidney transplant, all covered. It's that good. On Advantage, no. You pay a much lower premium, but now you pay as you go. The primary is 5 or 10. The specialist is 25 to 50. The emergency room was 120, and you took the ambulance. That's 280. Physical therapy, 40. You spent the night in the hospital, 300. It's an a la carte menu. You pay for services, but only as you utilize services. Network restrictions and co-payments for services with a potential for higher out-of-pocket, but for a potential of much lower expenditure. Back up one. The couple that's in the drug program and supplement, we said they could easily at 73, 74 be paying $500 a month between the two of them. That's a fictitious number, but it's a pretty good ballpark for somebody that's 74 years of age, a couple. But here, they know by paying that money, their worst case scenarios are going to pay $6,000 next year in premiums. A and B, additional. A and B, got to have A and B to do anything else. But they're paying $6,000 here because they know their worst case scenario is they paid $6,000 and everything's covered. But that's their worst case scenario. Their best case scenario, nothing goes wrong and they paid $6,000. That might have them intrigued in an idea of a pay-as-you-go platform. We never know. The cornerstone of insurance is what if. On an Advantage program, Everybody's value equation is different. Advantage might be attractive to somebody who has a higher risk tolerance, has very good health, whose doctors are in network, who are not afraid of perhaps a little bit higher worst case scenario. And these advantage programs come in two flavors, HMOs and PPOs. If we know the difference, HMO keeps everything within a single network. You're all Advocate, or you're all Northwestern, or you're all Dooley. I've got to keep it within that network. PPOs have grown in popularity because PPOs allow us to cross-pollinate. We've got doctors that are in Advocate. We can see doctors that are in Northwestern. We've got a couple of doctors in Dooley, and we don't need a referral on a PPO to be able to do that. Gives you more flexibility. As a result, the PPOs have grown in popularity, but they're still network restrictive.
Yes.
They still have co-payments for services, but perhaps one of the most important things of an Advantage program, we're at least putting in a cap, a worst case scenario, a maximum out of pocket, a firewall if it all goes wrong. These Advantage programs, HMOs will be a lower out of pocket. PPOs are doing more. They're giving you a broader berth and more doctors to be able to see. The PPOs will have a higher out of pocket, but we clearly want to look at that. We want to understand that they'll include a drug program built right into the chassis. And this is where there can be sweeteners hiding. Sometimes they treat prescription drugs more favorably than you would on a standalone drug program with original Medicare. We'd want to research that. One of the companies 5 years ago started offering insulin for a zero copay. That was huge. We moved a lot of people into that plan because it treated their meds so favorably. And these programs are available to us during the annual election period. You had your 1 year golden ticket on the supplement, but every year during the annual election period, the Advantage programs will welcome you with open arms. They don't care if you got pre-existing conditions. They don't care if you smoke. All they care about is they've built the hotel. They want to put as many people in there as they possibly can. Because remember, we said the government isn't running Medicare for your $164.90. Medicare's running over $1,000 a month for each of us. They'll take that money and send it to a private insurance company, and the private insurance company literally replaces original Medicare. You've still got Medicare, you've still got to pay for A and B, but you put that Medicare card away because now you've agreed to keep it all with a private insurance company. They're available on a county by county basis. That means that there's a different landscape throughout the United States. The one that your brother has in Missouri isn't available here. Something very similar is. And the beauty of this is Medicare forces all of them to lay their benefits out side by side. We can see at Medicare.gov how they're going to treat your medications, what the co-payments are. This idea of Advantage, including dental, vision, and hearing, and that's true. The ads aren't lying, but the ads are disingenuous. A benefit is different than insurance. Be aware of that. When they scream dental, vision, hearing, they never say insurance, they say benefits. Some of them can be pretty thin. We had a company a couple of years ago, the dental benefit was $250 as long as you went to their guy. $250 is barely a cleaning. One of the companies this year was touting $5,000 in dental. That's a grabber, $5,000 in dental. What does it cover? Cleanings. What? You couldn't run up $5,000 in cleanings if you went every day. Sometimes the benefits can be a little bit misleading. They're not telling the truth, but they're kind of bending those rules. Let's be aware though, some of them have gotten pretty benefit rich. There's a couple in here that are really wonderful when it comes to specific situations, and that's what we're talking about here. Everybody's different. Everybody's got a different value equation. Your health, your finances, your risk tolerance, your experience with insurance companies, how you access the insurance industry, all blend in to make you a unique individual. Don't do what your neighbor did. Don't do what the guy at work did. Research it yourself and make sense of these things. Slide. A and B, good, but not complete. Add a supplement, add a drug program. That's one pathway called original Medicare. A and B has specific timing issues. Be aware of those timing issues. Getting a supplement has specific timing issues. Be aware of those timing issues. And Part D has specific timing issues. We gotta be aware of this and understand how to move the pieces on the chessboard. This is a big game. I don't mean to be flip to call it a game, but if we don't understand how to move those pieces, you're not going to maximize your opportunity. One pathway called original Medicare. There's this other pathway. Drum roll, please.
Yeah, it's not gonna do it.
Okay.
I see it on.
The other
screen, I don't see
pathway,
it
the
there.
other pathway is called Medicare Advantage. Medicare Advantage is a pay-as-you-go platform. It's something where your worst case scenario could be several $1,000s, but your best case scenario could be far less. The idea of all of these pieces here in play for you now during the annual election period. Thank you for coming here tonight to learn a little bit more, happily shedding a little bit of light on that. Lori and I are brokers. We represent all the companies that sell these things. There's no charge to meet with us to help review your situation. The idea here is, did you choose wisely initially? I hope you did. But maybe there's some tune-ups that need to happen along the way. We have an office in Lisle. We do Zoom meetings all the time. Oh, there they are. The idea here is that by utilizing us, you're gonna shorten your learning curve. The prices that we are charging are the same prices that everyone's charging, whether you go through an 800 number, another broker, or go right online. The idea here, though, is that we can make it a smoother pathway and help you make the wise choices. We do education, one, because we love it. If you don't sense our passion, okay, love doing this. And all we ask is maybe a chance to take a look at what you've done, or catch you when you turn 65, or just when your friends ask you, how did you figure this out? It was so confusing. I want you to tell them, I got a guy, okay? Because that's what we do.
Or yeah.
There you go. Equal under the law. Questions? You guys must have something. I threw a lot at you and I talked fast because I had a cup of coffee. I'll go back first.
Just real quick, so. Not saying one's better than the other, but the advantage, they're advertising, hearing, vision and all that.
Mhm.
Do you get any of that under just regular Medicare?
With original Medicare, your vision is pretty much completely covered for the scary stuff. Medicare will cover you for glaucoma, cataracts, macular degeneration, detached retina, get a sty, poke your eye out. All that is covered under original Medicare. You want a new pair of glasses or lenses or contacts? No, Medicare is not going to pay for that. The Advantage programs would. They have programs. Again, difference between a benefit and insurance. The benefit on most of those Advantage programs could be $100, $200, $300 towards lenses and frames.
Okay, but like on regular insurance, and I haven't switched yet, even if you don't have vision, because I had to have cataracts done already,
I'm sorry.
the Blue Cross Blue Shield picked up the medical services part of it.
Of the cataracts.
Right, with Medicare do that.
Sure they would. 80-20.
80.
After
Okay.
your $226 deductible, they're gonna cover your cataracts, but they're gonna come at you with 20% of that bill.
Right,
Which on cataracts, I'm told about $5,000 per eye.
Yeah.
So that'd run you about $1,000 and about $1,000. Or you have a supplement that makes that go away completely. We always encourage people never to delay medically necessary treatments, but if, for example, you're waiting for the colonoscopy and the guy told you 5 years. He didn't say 5 years on the day. You got a little bit of swing in there, right? And if it's 5 years in a month or two, well, boy, you come to Medicare after 226, that's completely covered. Do it on an Advantage program. Worst case scenario, it's in out-of-pocket outpatient, maybe $200, $300. That's better than doing it, because I just had my free wellness colonoscopy, which is free wellness until they find something, and they always find something. And as soon as they remove it, it becomes a surgical procedure
Yes,
and a
and then
biopsy.
it becomes-
And my free colonoscopy was what, $1,600?
Double that.
It's like, it's so scary going in there, because they say, if you find something, this is gonna happen, this is gonna happen.
Well, the other thing too is they always put you next to the guy that the doctor comes in and says, you had 87 polyps. And you
Oh
go,
my God.
I
You're
feel
gonna
better about
swallow.
life, okay? I only
But
had.
you know, the question too about cataracts, that is the one and only time that Medicare will pay for glasses, is after cataract surgery. They pay for one pair of glasses after cataract surgery.
And
Very
how good is
cheap.
dental?
Amount they pay.
Yeah. But, so that is the only thing though, that when people come to regular Medicare, usually what they're doing, if they want dental and vision, you're not required to get dental and vision now with your employer coverage. That's an additional benefit that you're spending a little money to add on to your coverage usually. But typically what people will do is they'll add on, if they want to, dental and or vision.
Can you add it on, if you take regular Medicare, can you add that on to the supplemental?
Yes, well, you don't add it onto the supplement, it's an additional standalone policy. You purchase a policy from
Oh.
Delta Dental, you purchase a vision policy from VSP.
There's
They're-
no
they're-
supplement that covers dental.
Okay.
They're separate
They'll cover you for
policies.
disease and injury. Bust up your jaw, they'll make it right. Get jaw cancer, something, they'll do that. But you bust up your jaw in an accident, they're not cleaning the teeth as they're taking off the wires. That's maintenance. They don't pay for maintenance.
Okay.
Disease or injury is the trip on that.
And there is no, like, discount or any kind of thing through dental if you get a medical insurance and.
No, that's a standalone policy.
Okay, that's fine.
Standalone policy on that.
That's
Good
fine.
question.
Well, so on the drug, can I go back to the drugs? So, if, no, I said I've already been catastrophic for months.
Okay.
And actually, that's very beneficial to me because.
Well, you
Because it costs you less.
you paid a bunch up front
Yeah,
to get to the promised land where you paid very little.
but what happens is, in insulin, the insulin I take is going generic, which is good and bad, because if it goes generic, the cost is down, which means I might not get into catastrophic, right?
Also gotta be careful on the uptake of generic drugs. Frequently, you find that in the Part D drug programs, the generics, the brand new generics are actually more expensive than the brands that are being offset by the manufacturers. It looks like this year, though, I've run a couple of comparatives where the generic insulin is now less than the brand. So that's again, another reason why you want to take a look at this every year. Let's just be sure. Motto here, no surprises. People who call and they're shocked that they fell into the coverage gap. You didn't see this coming? You should every year be able to see what's coming down the road, okay? What else? What else? All right, I'll go.
I think you said with the Part C, there's some savings you could have if you bear more risk, right?
That's all insurance ever is. The more risk you assume, the lower the premiums. The more risk the insurance company assumes, the higher the premiums.
But you're talking about savings from part, in the other lane, savings from the Part D and the supplement.
Correct. That's where we want to make that comparative.
Okay,
And we'll find, actually in the world of Advantage now, there's a new world of Advantage coming. Most of the Advantage programs are gonna tout zero premium, but look behind the zero premium, the out-of-pocket is quite high. Now, one of the producers of these products has brought forth a different kind of Advantage program. No deductible, no co-insurance, no co-payments. It mimics the old F supplement and includes a drug program and allows you to see any doctor, any hospital, anywhere in the United States that takes Medicare, but it does charge a premium. It charges a significant premium. At 65, it doesn't make sense. At 70, it doesn't make sense. But at 75 or 80, where the premiums of your supplement and drug program have increased, there's a break point. And you'll find a place where the premiums that you're paying for your supplement and your drug program could be more than your worst case scenario on an Advantage program. That capped exposure, that's a tipping point. That's when people really start looking at Advantage seriously. Okay?
but for the A and B, I'm just a little confused on this, but for the A and B, that cost is built, it's just built in.
Well, it's coming out of your Social Security check if you're receiving Social Security. But if you're not receiving Social Security, they'll bill you for it quarterly.
But yes, it's a given. You are going to pay for
You're gonna
that,
pay
whether
that much.
you're on the original Medicare or the Advantage. That's between you and the government. You're not getting out of it.
That's that dunk, yeah, you're that dunk cost. You've got to have that to do anything else.
Yeah, so when you talk about savings, you're saving off that extra stuff you're doing in there.
Correct. And I predicted that someone would say here tonight, well, if I got an Advantage, I don't need to pay the part. No, you gotta have A and B to
And that's-
do anything else.
that's-
To get into the wonderland of Medicare, you've gotta have A and B.
It's not gonna change a dollar of it.
No,
The dollar change, the savings is off that extra stuff.
correct. All right, you guys, I think we did okay. Did we have any questions that were asked? No? All right, you guys, thank you.
Thank you, David and Lori. That was